Welcome back, all of you, to part two of Medicine Emergencies, where we are doing poisonings and bites. This is Dr. Chetanya Mittal. I've done my MBBS from AIMS New Delhi, and I'm currently pursuing my MD Medicine at JIPMER. So, we had talked in the previous section about poisonings, and in this, we had covered what was organophosphorus poisoning. In brief, we had looked at cell force poisoning. The important thing for Cellforce was that it is a mitochondrial toxin. Now, in this, we are looking at three bites. The first bite will be scorpion bite, snake bite, and finally dog bite. So, this will bring us to an end of important medicine emergencies. Of course, there are other miscellaneous emergencies that we have to look into. So, first of all, let's talk a little bit about scorpion sting. So, the main predominant thing that you have to write or that you have to remember in your examinations regarding scorpion stings is that it leads to a storm of the autonomic nervous system. So, there are three places in medicine where you read about storms. Okay, one is an autonomic storm, other is a cytokine storm, and third is a thyroid storm. So, there are three places where you will see storms in medicine, and one of them is scorpion sting. So there are a couple of interesting multiple choice questions that come out from here. And one more important thing is the antidote that will be asked to you, that will be prazosin. Okay. So these are the basic things or a basic framework that you have to remember. One more thing is you will have full autonomic nervous system activation, in which first you have parasympathetic nervous system followed by the sympathetic nervous system, ultimately leading to a cardiovascular crisis. So what you should write or what you should remember is the toxin here is an alpha toxin which acts on sodium channels. What it does, how it causes hyperexcitability and all, you can ignore. Alpha toxin acts on sodium channels and in effect it brings about autonomic nervous system activation, parasympathetic nervous system followed by the sympathetic nervous system, and therefore the antidote you use is prazosin. Why? Prazosin is a alpha blocker. So prazosin blocks uh, the sympathetic nervous system from getting activated, and that is how it is useful as an antidote in case of scorpion stings. So let's quickly walk through scorpions. It's also something that is covered in your forensic medicine on how to identify it and all. But I'll just quickly tell you that in Indian context, you have two. You have a red scorpion and you have a black scorpion. So I've written their names. The red one is called as the Mesobuthus. So remember, it is small and red means danger. So even though it is small, it is more dangerous because the venom is in the terminal segment of the tail. The venom for this scorpion is in the terminal segment of the tail. So how I identify it is that the black one has these sharp clippers and it looks more dangerous. It looks bigger, but it is actually less dangerous. This one does not have those clippers, so you're not able to identify based on red or black because essentially they will look similar. But what you have to look for is one, how the tail is. Second, the more important thing is the two claspers in front. Those will be more prominent. The black scorpion will be larger. But remember, it is larger, it looks more dangerous, it has more sharp claspers, but it is less poisonous. Okay. And it is a common scenario. It is common in Tamil Nadu, it's common in Pondicherry, it's common in the Western Ghats. So that is where you get these cases. And often you will see the history will be given like in it happened in the summer, okay, and somebody usually would have stepped on it or handled it. Only then you will get a scorpion bite. So these things might be mentioned or might not be mentioned in your question stem, or you might also get an image based question to identify the red on the black scorpions, the predominant types which are found in India. Pathophysiology, we have already discussed. This is what you should write. Alpha toxin causes prolonged depolarization of all autonomic neurons. Within the first 4 hours, you get the parasympathetic surge. So you get salivation, vomiting, sweating, bradycardia, hypotension, and very, very important here is priapism. So you get, so remember, parasympathetic nervous system causes erection and the sympathetic nervous system causes ejaculation, right? So this dictum you can remember. So that is why priapism is a very, very common or a very, very important thing that you can remember with regards to scorpion bite. Priapism means a prolonged boner, right? Then you go to the sympathetic nervous system surge, which is after the 4 hours. So 4 hours to up to 2 days that sympathetic surge can last. and now you will have tachycardia, hypertension, and all of this will ultimately can lead to cardiovascular collapse. One more important thing is when so much sympathetic nervous system happens, you have release of so many hormones, including noradrenaline, adrenaline. These catecholamines, what they do is they decrease insulin and cause hyperglycemia. So you can also have a DK-like presentation. Remember, noradrenaline, adrenaline, these are all anti-insulin hormones. So insulin tries to bring down your glucose levels, whereas all the other hormones, glucagon, cortisol, adrenaline, noradrenaline, they work as hyperglycemic molecules to prevent hypoglycemia. So when you have a catecholamine surge, inevitably you will have hyperglycemia. And this is the context you get in India. In India, you have these two main particular ones. However, in other continents, in other countries, you also have other forms of scorpion stings where you can have neurological features which are more predominant. So there is a grading based management which is there. There is an NEJM article on scorpion sting. You can go through that. This is sort of taken from there. So there are four grades of a scorpion sting: grade 1, grade 2, grade 3, grade 4. And it is based on this pathophysiology. So in grade 1 scorpion bite, you will only have pain. So the management for that will be for the pain. You will give an ice pack, you will give a nice NSAID to suppress the pain, and you can also put a lignocaine ring block around where you have. So one recommendation here is do not apply ice directly to the skin because it will cause severe vasoconstriction. Already there might be some sympathetic nervous system activation, so you might have ischemia due to it. So you will not have any systemic symptoms in grade 1 bites. Grade 2 bites are the early bites which are in the cholinergic phase, where the main symptoms are vomiting, sweating, bradycardia, priapism, right? In these cases, you will give prazosin. You will give prazosin 30 mics per kg. Maximum dose you give is 0.5 mg. Maximum 0.5 mg prazosin you will give to such a patient because otherwise you may have worsening of the hypotension. And unless the bradycardia is symptomatic, you do not give any atropine and you monitor the patient. For fever, you can give paracetamol. In this case, for pain, you can give paracetamol. When the patient progresses to grade 3, when there is cold extremities, tachycardia, hypertension, pulmonary edema, when all of these are there, this is an indication for ICU admission. You have to supplement oxygen because there is hypertension and there is pulmonary edema. With positive pressure ventilation, you will clear out the pulmonary edema, and here you also give prazosin plus scorpion antivenom. Because there is cardiovascular dysfunction, dobutamine for the cardiovascular dysfunction and nitroglycerin for the hypertensive pulmonary edema may be used. Final phase is a multi-organ failure where you get altered consciousness and end organ damage. For example, they tell you that the patient has altered consciousness. It means that the hypoperfusion has gone to such an extent that there is end organ damage. For example, renal dysfunction, dysfunction of the liver, dysfunction of the brain, all of these are end organs. So it represents a very severe stage where you will have to use infusion of benzodiazepine to calm the patient because there is altered consciousness. You will obviously have to intubate, give mechanical ventilation, and of course, we are administering prazosin. So what you can see from here is that in grade 2, grade 3, and grade 4 bites, in all of these, we are going to go ahead and give prazosin. How much? 30 mics per kg if it's a child. Adult maximum dose will come out to be 0.5 milligrams, which is an alpha 1 blocker. It is the first line. The other aspect that we were adding was a diazepam, which we were giving in case of for the anxiety part, for the antagonization of the sodium channel toxin effect, and that can be given. Antivenom, it is not routinely recommended. There is some recommendation in grade 3 bites, but that is not commonly used in the Indian setting. So that was regarding scorpion bite. Now scorpion sting has some relevance in medicine. There are three places where you get scorpion stings as a clinical stem or in a buzzword format, wherein you will be given a question where they'll give you a history of scorpion bite. Okay. And these are also sometimes useful in clinical contexts. I had a patient who had cardiomyopathy, which we do not know a cause. It was a young man. After taking a good history, we found that he had history of scorpion bite in the childhood. So most important is scorpion myocarditis. It is a known factor for causing dilated cardiomyopathy, DCM. It is a known factor to cause dilated cardiomyopathy. Second thing, which is also mentioned in your first aid, is that scorpion stings can cause acute pancreatitis. So non-alcoholic person without any gallstone comes to you with sudden abdominal pain. enzymes amylase lipase are elevated, so you will get, and he might have a history of having gone to the Caribbean recently. In this scenario, you should think of a scorpion pancreatitis. Last thing that we have discussed is there is severe hyperglycemia in scorpion bite. So in a diabetic, it may precipitate diabetic ketoacidosis in such a case. So three places where scorpion stings are relevant is scorpion myocarditis, scorpion pancreatitis, and scorpion sting induced diabetic ketoacidosis. So you can just remember this. This will also be very useful in a clinical context to you. After scorpion bite, we move on to snake bite. So snake bite in Indian context is limited to the management using four snakes. Okay. There are multiple other snakes in the world. There are many types of snakes, but what you have to remember first and foremost is most of the snake bites are by non-venomous snakes. So oftentimes whenever you have a death in snake bite, that is often due to the anxiety or the fear response. So first thing to do will be reassurance in these cases that it is likely to be a non-venomous snake. There are very few venomous snakes, and in Indian context you only have to know four main snakes for which you have anti-snake venom. So every country will have a different anti-snake venom. The Indian anti-snake venom covers the big four of India. You may have other snakes in, especially in African countries, in other, in the Amazon rainforest, you have other types of snakes which are not commonly found in India. So in the Indian context, you talk about the big four venomous snakes of India: Great cobra, viper, viper. Okay, so you have the common crate, the Indian cobra, the king cobra, the Russell's viper, the saw-scaled viper. I'm not discussing the other snakes like the common cobra or the yellow banded crate. Okay, those are other forms that exist, but I'll be talking about the four venomous snakes that you need to remember and you need to write down in your examination. So first one is common crate, other one is Indian cobra, Russell's viper, and the saw-scaled viper. So remember, broadly here, if you want to look at it, these two cause a neurogenic snake bite or a, okay, they will mainly affect your, so these are neurological snake bites. These will predominantly have, these are called as hematotoxic snake bites or hemotoxic snake bites. So that is based on what effects they have. Okay. So very important here is crate versus cobra. The very important thing is the mechanism by which their toxins work. So we will have a small discussion before I proceed. I'll just quickly tell you the mechanism. So what happens in cobra bite and what happens in crate bite is something you should remember. So mechanism of action is a Pangaro toxin. So you have crate and you have cobra. So you should remember that for crate you have beta and for cobra you have alpha Bangaro toxin. The beta bungarotoxin acts on the presynaptic area, whereas the alpha bungarotoxin acts on the postsynaptic area. Okay, so it goes and it binds to the acetylcholine receptor, the alpha toxin. So first thing to remember is that crate has a presynaptic mechanism of action, whereas the cobra bungarotoxin has a postsynaptic mechanism of action. Now, because it acts on the postsynaptic area, what you can do here is you can give neostigmine. What neostigmine does is it inhibits acetylcholine esterase. By inhibiting acetylcholine esterase, it increases the acetylcholine molecules that are present in the synapse. So they will compete with the alpha bungarotoxin and it will not allow the alpha bungarotoxin to bind. So it prevents the toxicity. So neostigmine will be useful in post-synaptic mechanisms. Whereas in beta, when you have a pre-synaptic mechanism, already all the acetylcholine has gone out. So you cannot use neostigmine to increase post-synaptic effects or to modulate the post-synaptic effects. So in crate bite, the important thing to learn is that in crate bite, it is not useful to give neostigmine, whereas in cobra bite, there is benefit of neostigmine. That is the first and the foremost and the most important concept that you have to take home from snake bite. Second thing that you should take from snake bite is that you should remember what happens with viper bites. So viper bites there are two things. Viper bites will cause procoagulant state. They will increase various factors, and as a result, they will cause consumptive coagulopathy. And when those factors are used, you will enter into a state known as disseminated intravascular disseminated intravascular coagulopathy, DIC. And when you have DIC, you will have severe bleeding manifestations, and that is the hemotoxic effect of viper bites. There are other mechanisms through which it will cause acute kidney injury. So you will can have renal dysfunction in the form of increased urea creatinine. And other thing is that this procoagulant state that precipitates, sometimes what can happen is in localized areas of circulation, for example, in the cerebral circulation, you can get a cerebral venous thrombosis or CVT due to the localized state of procoagulation. So these are the important points that you should remember. You need not go into too much details of the mechanisms, but these are the things that you should remember. Important things are beta bungarotoxin and alpha bungarotoxin. Now, I'll tell you the context in which these scenarios will be given to you, or the hints that can be given. One thing is that you can be shown an image. So remember, the thing for crate that you have to remember is that there will be bands. It will have bands present on its body. So that is how you will identify that it is a crate. How do you identify a cobra? By the hood. They will show you a snake with a hood. Remember, common cobra versus king cobra, the difference is with regards to the spectacles that are present here on the body. Okay, but you need not go into that difference. If you are shown a hood, you mark it as a Indian cobra or a king cobra. In forensic medicine, they'll tell you more details on how to identify these bites and all that. Then you talk about Russell's viper and the saw-scaled viper. So viper, how do you identify is you identify in the V-shaped form of the scales that are present all over the body. The saw-scaled viper will be more red in color. The scales will be red in appearance. So these are the four main types and how to identify them. Now, what are the hints that can be given to you in an MCQ format is one, in crate bite, they will tell you that the patient was sleeping at night. Morning when he woke up, he found some symptoms and something. So often the crate bite will be a occult bite. It is a painless bite. The patient will not know. So how do you differentiate it from a cobra bite? Cobra bite is often a painful bite, and it will have local necrosis or local necrosis manifestations. It is also good idea. It is a good idea in clinical practice to know the local names. That cobra is called Nag, what Kala Nag, and what all these terms mean, you should know in your local language whenever you are practicing. Now, the common crate, what it does is it acts at the presynaptic area and it destroys the acetylcholine vesicles. Okay, it is mainly active at the night. People who sleep on the floor are at risk, and often you will find a villager who was sleeping at his home at night on the floor, did not come to know anything in the night, but morning when he woke up, he is not able to breathe, he is not able to swallow, and all these features set in. You should think of a crate bite, and patient may get paralyzed, and you can have a locked in syndrome kind of a presentation. And what you should remember here is that neostigmine is not helpful. Why? Because it is a presynaptic insult. In case of cobra, the patient will have severe pain, local site reaction causing cell death and gangrene can happen, and it is due to postsynaptic blockade of acetylcholine receptors. So if you give neostigmine, there is increased action of acetylcholine because of blockage of the acetylcholine esterase enzyme. It also has cardiotoxic effects due to this cell death mechanism of action. Then Russell's viper, it causes severe DIC, so patient will have bleeding from everywhere. What other thing is common is there will be acute kidney injury. You can get cerebral arterial thrombosis. You can get cerebral thrombosis, both CVT and CAT. You can get a stroke. You can get a viper's bite patient presenting with a stroke. Apart from that, you can have a pituitary infarction, which will be like a Sheehan syndrome, like of a presentation where patient will have hypopituitarism, right? Then you have saw-scaled viper, where AKI is relatively rare. The more common thing to happen is DIC, and it is responsible for the most deaths. What will be given in the scenario is that the patient heard a rasping sound, a sizzling rasping sound before the bite, and that will give you a hint that it is a saw-scaled viper. It is a smaller snake, but remember, the one that is smaller is more potent, causes more deaths. That was true in case of scorpion bite also. Now, we have already discussed this. So, your crate and cobra belong to the snake family of Elapidae, which are neurotoxic, elapid, right? So elapid venoms, cobra and crate both cause blockade but by different mechanisms. We have already discussed this, that beta bungarotoxin acts at the presynaptic whereas alpha acts at the postsynaptic, and because of this the paralysis is curare like. That is why it can be reversed by neostigmine, and the receptor blockade is inhibited. The receptor blockade is relieved because it is a competitive antagonism, right? Cobra, apart from having the alpha bungarotoxin, also has a cytotoxin which is responsible for the gangrene at the bite, and it also causes cardiovascular toxicity. On the other hand, viper venoms, these are elapid venoms. Viper venoms, they are cytotoxic. There is a procoagulant state due to clotting factor activation causing DIC and paradoxical bleeding. At the same time, you can get cerebral arterial thrombosis. The hemolytic effect is due to phospholipase A2. It can also have some myolytic effect because of which you can get elevation of CK levels. Creatine kinase levels may be elevated and there may be myotoxicity. Apart from that, it is having nephrotoxin also, which is causing acute kidney injury. So, elapid venoms, what are the toxin? You have bungarotoxin, beta and alpha. Along with that, cobra can also have cytotoxin. In vipers, you have cytotoxins, procoagulant toxins, hemolytic myotoxic toxins, which is phospholipase A2, and you have nephrotoxic venoms. Right? You have nephrotoxic toxins in the bite. So here again, we have had a small discussion that the action for the crate will be at the presynaptic area, and you have the snare proteins here. And at the postsynaptic membrane, you will mainly find the action of the cobra bite. So neostigmine will be useful, right? We have discussed this syndromes. So you have broadly three syndromes in snake bites. The elapids will cause neuroparalytic, the vipers will cause vasculotoxic, and sea snakes will cause a myotoxic syndrome. Sea snakes. How do you identify that this is a sea snake? The easiest way to identify is that you are shown that the snake is lying on the beach. So this photo is taken from Wikipedia. So whenever you see a snake and you see sand or mud around it, it is likely to be a sea snake that they are trying to show you. And remember, it is myotoxic. It does not included in the anti-snake venom, right? Neuroparalytic snake bite, first sign you may see will be drooping of eyelids, ptosis. Then you might see that you are not able to have eye movement. So you will have external ophthalmoplegia, double vision. So 5Ds, diplopia, dysarthria, dysphonia, dysphagia, and dyspnea. So whenever you see a patient who has double vision, is not able to speak, bulbar palsy kind of a presentation, and was sleeping on the floor at night, suddenly happened in the morning, always think of a snake bite. Do not delay anti-snake venom in such cases. So 5Ds and 2Ps, the 2Ps are ptosis and paralysis. So paralysis, you can have a locked-in syndrome kind of a presentation. Deep tendon reflexes will be diminished or absent. Why? Because it affects the nerve muscle junction. So it is a lower motor neuron kind of a palsy. It is a element type of weakness. So you will have diminished or absent DTRs. Do not confuse this with GBS. Okay, you will have neck weakness and you can also have respiratory failure due to NMJ paralysis. In vascular toxic bite, you will have bleeding. So you can have bleeding gums, you can have epistaxis, hematuria, melena. Other possibility will be that you can have AKI, which is more common with Russell's viper rather than saw-scaled viper. You can have cerebral arterial thrombosis with Russell's viper or anterior pituitary infarction. And you can also get intracranial hemorrhage. So remember, here you can get cerebral arterial thrombosis as well as you can get cerebral hemorrhage. Both are possible. And one more important thing, how do you test for hematotoxicity is you do something called as you take some glass test tubes, you take the patient's blood and you put it in the test tube. If it does not clot within 20 minutes, it represents that coagulation time is prolonged and it represents a DIC. So in the, especially when you are in your rural postings, often you will be doing the whole blood clotting time. That is called as a WBCT. If WBCT is clotted, you can sometimes be assured that it is not a viper snake bite. Okay. But you have to do serial whole blood clotting times. You have to do it again and again. Right. But if it is not clotted, you should immediately give anti-snake venom. It is an indication to give ASV. So the WBCT is a very, very important test when it comes to snake bites. And I already told you that very important thing to do is reassurance, because 70% of the bites are non-venomous and you will mainly have anxiety which is causing all the symptoms. Palpitations, paresthesia, pupil dilatation, tachycardia, all these might happen and you might think that these are neurotoxic manifestations, but they can often be anxiety related. So, what is the management of snake bite? The field management, that is out of hospital. Whenever you say field management, you mean out of hospital. So, you will do reassure that 70% bites are non-venomous. Second thing, you will immobilize the limb, and often in the Indian context. So wherever you read this from, you have to read it from the National Health Mission Management of Snake Bites. There is almost an 80-page PDF on how to manage snake bites. Especially when you are in internship, you should definitely go through it. So often what they will do in villages is they will tie a tourniquet or give an incision or give suction the venom with their mouth, give a shock, apply ice packs. All of this you should not do. All of this manipulation is not recommended. Only thing is that you should immobilize the bitten limb, you should splint it, and you should get the patient to hospital, prevent harm. So they will mention all the don'ts and tell the doctor the description of the snake. Often what you have seen and what I have commonly seen is you will have a patient who walks in, they will be nicely bringing the snake to you. Often, I've always seen a dead snake, but I'm always scared that it will turn out to be a live snake. They will bring it in a polythene, and then sometimes you will ask Google Lens to identify what the snake is. Or if you're a very good at identification, you might be able to get a correlation with one of these images. So if you know the snake bite, there are some indications when you have to give anti-snake venom. So two things in the management that you should be knowing, and especially you should write in your theory examinations, is one is about anti-snake venom, second is about neostigmin. So I've emphasized a lot. Neostigmin, give for cobra, do not give for crate. How much you give? Neostigmin, before giving neostigmin, you should give atropine. Why you should give atropine before giving neostigmin is a pharmacological principle. Neostigmin causes increased cholinergic symptoms. So what will happen is the patient will have lots of secretions. Okay, so it's a very beautiful thing. Give me 1 minute. I'll discuss why you give atropine before giving neostigmin. It's again ties into fundamental pharmacology. Uh, Okay, and it will also kind of correlate with what you have studied in organophosphorus compound poisoning. So what neostigmin does is it blocks the acetylcholinesterase. So what it does is it increases the acetylcholine in the synapse. So you are primarily giving it for the weakness part. So there will be nicotinic receptors and there will be muscarinic receptors. So what you want is you want a nicotinic action. But often there will be undesirable muscarinic action due to neostigmin in the form of vomiting, increased secretions causing bronchoria, all the manifestations of sludge which you had seen in case of OP poisoning. So to block all this, you will give a dose of atropine. You will give atropine, which will cause blockade of the muscarinic receptors, whereas the nicotinic action will be continued. So that is the reason why you give atropine before giving neostigmin. So give atropine 0.6 mg followed by 1.5 mg of neostigmin, then 0.5 mg neostigmin plus atropine every 30 minutes up to 5 doses at 1, 2, 6 and 12 hours. If there is no improvement after 3 doses, it suggests that it is not a cobra bite, rather it is a date bite, and you should stop giving further neostigmin. Okay. The anti-snake venom, you have a polyvalent anti-snake venom in India made from the big four cobra crate, Russell's and saw-scaled. It is made in horses, so there is a great risk of anaphylaxis, right? So what are the indications to give anti-snake venom? Due to there should either be extensive local damage in the form of swelling which crosses a joint or involvement of more than one half of the limb in 48 hours. So either there should be very severe local symptoms or very severe local symptoms, or there should be systemic symptoms. For example, if there is ptosis or if there is dysphagia or dysarthria, these are all indications to give anti-snake venom, right? So, or if the whole blood clotting time is more than 20 minutes. In these cases, you will give anti-snake venom. Initial dose, the dose is 10 vials IV. So remember, one very important thing is that the dose here is actually based on the amount of venom. Okay, in most drugs in medicine, the doses will be based on the weight. For example, in case of scorpion sting, you were giving a dose of prazosin that was 30 mics per kg up to 0.5 milligram. In case of anti-snake venom, it is not to counteract a body's response. It is to counteract the venom. So remember, the venom injected by a snake does not depend on the body weight of the patient. So even in a 2-year-old child, you have to give the same dose of anti-snake venom that you will give to a 40-year-old gym going 80 kg person. Okay, so irrespective of weight, you will give, usually what we give is 10 vials IV, which is equivalent to neutralization of 6 milligrams of viper venom per vial. Okay, how do you give it? You can give a bolus or you can give a infusion over 1 hour. Usually we prefer to give an infusion to avoid severe anaphylaxis. If you have a previous history of anaphylaxis or history, you should not give it because the anaphylaxis can be very severe. You should keep adrenaline ready to counteract any anaphylactic reaction. So expected reactions are in the early phase, up to 3 hours, you can expect itching, some vomiting, and in these cases, you can stop the ASV for some time, give epinephrine, give Avil, Hydrocort, and after that, you can consider restarting depending on the severity because it is a life-saving drug. Then next thing is pyrogenic phase. Pyrogenic reactions can occur in 1 to 2 hours. You can get fever, hypotension, chills. Delayed phase will be a type 3 hypersensitivity reaction in the form of a serum sickness to ASV. So it will be a type 3 hypersensitivity where you have formation of immune complexes. They will deposit in your joints, causing arthritis. They will deposit in your kidneys, causing nephritis. They will deposit in your vessels, causing vasculitis. That is common to all type 3 hypersensitivity reactions. So a serum sickness like reaction you can experience with anti-snake venom within 1 to 12 days. And finally, patient can be observed 24-hour observation. If otherwise, if you have given ASV, you should observe the patient for at least 2 days and then patient can be discharged. So management wise, you should know about anti-snake venom. You should be able to write a note on anti-snake venom. What are the toxins that are covered? What are the indications for giving it? What is the dose? The dose is independent of age. What is the administration? What are the contraindications and what are the expected reactions? If you get a reaction, what are the options you have? You have to give adrenaline if it is an anaphylactic reaction. Otherwise, you can give antihistaminics like chlorpheniramine. Along with that, you can give some steroids that can be hydrocortisone. So that is all about snake bite. Last and very quickly, we come to the, the most commonly encountered bite, especially in the OPD setting. Often you will get scorpion stings and snake bites in the emergency, in the inpatient setting. Dog bite until you get rabies will be in the form of a OPD patient who tells you that there is a history of a dog bite or a cat bite. So you should know the category of bite. You should know when to give immunoglobulin and you should know the schedule of vaccination for such patients. So what are the categories? So WHO here is the defining authority for the category. So what is the category? So you have category 1, category 2 and category 3 bites. So remember, whenever there is blood, it is a category 3 bite. Remember, whenever there is blood, it is a category 3 bite. So category 3 bites are important because they require immunoglobulin. So remember, category 1 bite is a bite with slight risk and it involves intact skin and the exposure is in the form of licks. So licks on intact skin is a category 1 bite. It only requires washing the area with soap and water with application of antiseptics. Category 2 bites, there is nibbling of uncovered skin, but remember here there should be no blood. For example, you have a wound and a dog comes and simply nibbles on it, right? Or there is a minor abrasion without bleeding, it is a category 2 bite, and you should get rabies vaccine. You should get rabies vaccine in this case, but you need not get immunoglobulin. However, if there are multiple transdermal bites, single or multiple transdermal bites, or licks on broken skin, licks on broken skin with contamination of mucous membranes with saliva. Okay, remember, nibbling of uncovered skin is different, licks on broken skin is different. Okay, if somebody comes and nibbles your hand, that is different. If there is a wound and there is nibbling, that is a direct exposure. It should be treated as a category 3 bite. All bites by wild animals are category 3 irrespective of what animal it was. Okay, you should manage the wound. You should give immunoglobulin and some of the immunoglobulin should be infiltrated into the wound. Apart from that, you have to give a full course of rabies vaccination. Remember, first thing to do is to wash the wound with generous amounts of water, generous amounts of soap, apply an antiseptic like betadine, and you do not suture it immediately. If you have to suture it at all, it has to be delayed suturing. And previous guidelines used to talk about whether the bite is provoked or unprovoked, whether and to observe the enemy. So sometimes they tell you to observe the dog for 10 days if it is a, especially if it is a pet who is vaccinated. But remember, rabies is fatal but completely preventable. So even if it is a vaccinated pet, I would not advise someone who is not vaccinated to take any risk, any chance. You should go ahead and get vaccinated. So rabies immunoglobulin, it's a interesting thing. You have two forms, the human one, which is quite expensive, and an equine one, which is cheaper. So the dose of the human one is 20 units per kg. Equine one, the dose is double, 40 units per kg. Okay. It has to be given only once and give it as early as possible, but not beyond day 7 after first vaccine. Okay. You have to give maximum as much as you can into the wound. For example, if it is a wound on the leg, you can give quite some quantity into the leg. However, when I had a dog bite, it was on my little finger, so it was very painful. Only some 1 ml could be infiltrated in the wound. The rest of it can be given as a injection, right? So you can give the remainder in the at a distant site in a intramuscular injection. Never inject the immunoglobulin at the same site as the vaccine, because both of these will neutralize each other. So the reason they tell you to give it not beyond day 7 of the vaccine is because if you have given the vaccine, immune response would have developed. If you are giving immunoglobulin on top of it, it will only neutralize the vaccine and it will decrease the efficacy. So do not give the immunoglobulin at the same site as the vaccine. So if you're giving vaccine on the right deltoid, give the immunoglobulin in the femoral or in the muscle of the thigh, the quadriceps, right? And if you do not have it, you should go ahead and give vaccine. And unavailability of immunoglobulin should not delay your vaccine. Okay, it is given only in category 3 bites, only given once, only needs to be given once. And what is the schedule of the vaccine? So you have a pre-exposure post prophylaxis. For example, if you are a healthcare professional who has admitted a case of rabies, you should get pre-exposure prophylaxis. Post-exposure prophylaxis is after getting bitten by a dog. You give post-exposure prophylaxis. In post-exposure prophylaxis, there is an intradermal regimen and there is a intramuscular regimen. So the intradermal regimen is called as the intradermal regimen is called as the modified thigh Red Cross regimen. Okay, it involves 4 injections instead of the usual. It involves 4 injections, whereas the one in the intramuscular regimen you have your typical 5 injections. So what I have used commonly is the intramuscular. Now often we have started to use the modified thigh Red Cross. So what is the WHO regimen? It is 0.5 ml given intramusculars on day 0, 3, 7, 14, 28. The modified thigh Red Cross tells you to give only zero point 0.5 point instead of 0.5 ml, it tells you to give zero point 0.1 ml intradermal into two, that is at two sites. So you have to give it intradermal at two different sites. Okay, for example, you can give it intradermal at left and right deltoid, 0.1 0.1 ml each. What is the benefit is that they have shown one, intradermal administration has good efficacy. Second, you are saving on the amount of rabies vaccine that you are using. For example, at a PHC you have only one vial of rabies vaccine. So if you use the entire 0.5 ml intramuscular, you'll only be able to give vaccine to one patient. But if you're giving through the intradermal route, you can give zero point 0.2 ml to two patients. So you can use 0.4 ml, and if you have two vials, you can use it for 5 patients. Okay, so I hope you understand the advantage. Another advantage is they say you have to give lesser doses for it. So previous teaching was 0, 3, 7, 28. Now with time these are also getting modified. There are some people are telling only 037 is enough. However, I will advise you from whatever so far I have done, do not take a chance when it comes to rabies. You go ahead and give two doses on 037 and 28. But what guidelines now tell for post exposure prophylaxis, especially international guidelines, even the day 28 dose they are starting to cut off. But mainly in your exam you can write the WHO regimen and the modified Thai Red Cross regimen. Okay, and sometimes here now in India you are able to get rabies immunoglobulin. It's actually very costly, uh, 750 units in 5 ml. So what happens is you are supposed to give 20 units per kg. So example, in a man who is around let's say 50 kg, you have to give 1000 units. So it will come to be somewhere around. You have to give one full 5 ml vial. Along with that, you have to give some 250 units additional. So you can infiltrate whatever 1 ml, 2 ml is possible into the wound itself. Rest you can give as a intramuscular injection apart from where you have given the rabies vaccine. Okay. So I had actually made a pro forma. So in my rural posting, we used to get a lot of patients of dog bite, and individually we had to write everything. So this is a good pro forma to go by where you can note down the important details. So remember, you have to take a short history on what happened. When did the dog bite happen? What was the site? Is there any indicator of infection or neurovascular compromise which needs any other intervention? What is the category of exposure? What is the previous history of rabies immunization? And what is the body weight? First thing to always do will be wound care, which means washing the wound properly. Then you will give the anti-rabies vaccine, which can be in the form of a intramuscular dosing or the thyroid cross. Okay, the SN regimen is the WHO regimen, which is the intramuscular. Then you can give a immunoglobulin, which can be equine or human. Human dose is 20 units per kg. Wound suturing, especially delayed suturing if indicated. Also remember, these patients you should give a prophylaxis of tetanus. You should give tetanus prophylaxis to these patients if they have not received recently. If it is a dirty wound, you may also have to give tetanus immunoglobulin, that is called as TET-glob. You can have to give TET-glob. Then, if indicated, if it is looking like a dirty or an infected dog bite wound, there is a lot of dust or mud in it, give antibiotic prophylaxis. If required for intravenous antibiotics, you have to admit the patient, or you can just give off amoxiclav to the patient if it is not such a severe, uh, if the wound is not very dirty or it does not require any debridement. And then you give a good counseling to the patient regarding what will happen, what is the importance of compliance. And very, very important, I feel, is you should give a table or you should give a course of the treatment record so that the next time when they come on their day 3 to get a vaccine, it is very simple, that and they do not miss any doses, and they're properly getting the post exposure prophylaxis. I spent some 5 minutes on this because I feel this is very, very important. Irrespective of what doctor you become, managing a dog bite will always be a critical part of being a doctor. Okay, and you should never miss it, because once you see a case of rabies, you will never forget, and once you see a case of rabies, you'll realize that it is 100% fatal and it was something which was preventable. Okay. So thank you so much. That brings us to an end of all the poisonings and bites that I wanted to discuss in detail. Okay, so we have discussed the scorpion sting, the snake bite, and the dog bite. I am not saying these are all the poisonings and bites that you need to know, but I feel these are the important things that are very likely to come up in your theory examinations as well as MCQs in your INICT, NEET, PG, FMG, and even the principles of this management stay true in the United States medical MLE examination. So you can also get the same there. Okay, so important things in OP poisoning was the end point for atropine is making the patient dry. Alphos poisoning, what we remembered was that it is a protoplasmic poison, mitochondrial poison. There is no antidote. It kills by affecting the cardiovascular system. Scorpion, the red scorpion is dangerous. Prazosin is a first line drug, and you have a characteristic manifestation in the form of priapism. It can cause myocarditis, pancreatitis, and DK, scorpion sting. Snake bites, the big four of India, in which crate is presynaptic, cobra is postsynaptic, which is why neostigmine works. Vipers cause DIC, in which Russell's viper also causes AKI, cerebral arterial thrombosis, pituitary infarction, whereas you have the more dangerous saw-scaled viper where AKI is less common. ASV 10 vials irrespective of age. Know the indications, know the contraindication. Finally, rabies, when to give rabies immunoglobulin, what is category 3 bite, and the vaccination schedule. Remember, it is preferable to give the vaccine as deltoid, and in a category 2 bite, there is no concept of rabies immunoglobulin. Apart from that, you can read about pre-exposure prophylaxis. That can be a question on how to give pre-exposure prophylaxis, and those details we have mentioned here. What is PrEP or what is pre-exposure prophylaxis? And then there is a re-exposure. That means that patient was already having a PrEP or a PEP, and again the patient has had a dog bite. Okay, so these are some additional points that you can go to, and that is kind of important. Okay, so that brings us to an end of poisonings and bite. And you can go ahead and revise this. I'll try to get the notes available for all of you. Thank you so much.